So it's my great pleasure to introduce Dr. Doobay, who is our speaker for tonight, emergency medicine resident at NYU Bellevue. She grew up in Jamaica, Queens, and she has been involved in service, advocacy, and social justice initiatives in her community and beyond from a very young age. Dr. Doobay founded and currently organizes an intersectional, cross-functional collaboration among the medical community, community-based organizations, the public health community, and the legal sector in New York City to begin to address racism, personally mediated racism, internalized racism, and structural racism, which is itself a primary driver of health inequalities. The action-oriented collective, the New York City Coalition to Dismantle Racism in the Health System, consists of more than 40 member organizations and 500 members. She is frequently invited as a speaker to deliver talks and workshops on racism, advocacy, and coalition building. She has also delivered evidence-based testimonials at city council and congressional hearings, and has organized citywide action-oriented protests on issues of equity in New York City. Dr. Doobay has also conducted community-based translational clinical research. She completed her master's research on vitamin D deficiency and sickle cell disease, and developed a tool to assess hepatitis sigma in communities of color. She is on the state board of Doctors for America, New York, and the New York City Department of Health's Narrative Power Network Planning Committee, and has received numerous awards, including 4 City Council State Senate citations, the Medical Society of the State of New York Community Service Award, and the Marshall England Memorial Public Health Award. It is our pleasure to welcome Dr. Doobay, and she's going to get started.
Thank you so much, Dr. Rockas, for that beautiful but totally undeserved and way too long introduction. It is truly a pleasure to be with all of you tonight. I'm humbled and honored to be with all of you. I always say that my favorite to speak with are psychiatrists, simply because you all are the humanistic of medicine. That's what I feel. So really here tonight, really what I typically do is a workshop. Time may not really permit a full workshop here tonight, but I want you all to, for us all here tonight, to create a space that is respectful, where all of us can contribute positively, productively, and with an open mind. I always avoid using the word safe because people are disproportionately affected by what we're going to be talking about tonight. It may not feel safe, but I hope to create a transparent space where we can all share with each other. Give the respect that you would want to receive. You may disagree with another person's opinion, but not necessarily that person. Speak only for yourself. Never assume that another person shares your opinion. Never ask someone to speak on behalf of their gender, their race, their sexual identity. And lastly, we recognize once again that certain people who have maybe of a certain race, gender, ethnicity may be disproportionately affected. So we recognize that from the onset. Please just jump right in if you have a question, if you have a comment. There's so many people on this call with varying levels of, opinions, and certainly so much expertise and talent. So please don't be shy and don't hesitate to jump right in. So during this of white supremacy and structural racism that drives both structural and individual racism within medicine, will identify anti-racist clinical skills to mitigate structural and individual racism, will assess as much as possible the available evidence and historical frameworks underlying common medical practices that contribute to bias and racism in clinical practice, and then we'll move outward from personal introspection to a more citywide landscape and look at segregated care in New York City. We'll define what that means, and we'll discuss the principles needed for individual and institutional anti-racist transformation. So a lot of organizations, salary buyer that we're training within, are conducting unconscious bias workshops. However, we've seen with the data so far that unconscious bias workshops often lead to awareness, but that awareness doesn't always translate into action-oriented initiatives or change. So we are of the belief, our coalition, and I personally, that we must conduct anti-racism workshops if we truly want to lead this or transform this awareness into change. Unconscious bias, though, are mental associations without awareness, intention, control. And what we often fail to recognize is that these are, they often conflict with conscious attitudes, behaviors, intentions, and are deeply rooted in and supported by all of these social constructs. So race, class, power, and these are based in structural divisions. So as clinicians, we walk into a patient's room and we must recognize our own biases, and we must recognize or think about the biases that others may have of us based on our accent, how we look, whether or not we're using a cane, our hand dominance, our weight, our communication style, and so many other constructs. So if you can unmute yourself, please tell me what comes to mind when you see this individual. Quick thoughts.
He looks pretty tough.
Tough, okay. You always get tough.
I know him.
Okay. Don't share. Any other?
Intimidating. Felon, former felon.
Sorry?
I heard someone say intimidating.
Okay, intimidating, tough. Anything else?
He looks angry.
Angry. All right, what about this woman?
He reminds, oh, sorry.
Oh, sorry, go ahead.
Yeah, he reminds me of that big guy on the 5 on Fox.
Yeah.
Big guy with a beard. He's really a very sweet guy, actually.
Okay, all right. What about this woman?
Librarian.
All right, always get the librarian. Yep. What else?
Everybody's mother.
Okay, motherly.
Maybe sweet.
All right, sweet.
Loving, caring grandma.
Loving, caring grandma. All right, love it. And this woman.
Professional.
Sweet and honest.
Sweet and honest.
Warm, approachable.
Warm and approachable. Okay. So this man here is John Fetterman. He's the former mayor of Braddock, Pennsylvania, and the current lieutenant governor of Pennsylvania. The tattoo here on his arm that many folks often mention is his zip code. He has a master's degree in public policy from Harvard, and he received international media attention for his economic revitalization programming that he started in his own community. This, often described as motherly woman, is Nanny Doss. She's an American serial killer. She confessed to killing 11 people, including her ex-husbands, her children, her mother, and her sisters. She's often referred to as the giggling granny or the Black Widow. This here, some of you may be familiar with. She is Mae Johnson, an engineer, physician, professor. She's the first African-American woman in space. She resigned from NASA to found a company researching the application of technology to daily life. So we just see here, just based on how someone looks, just one photo, what our mental associations are, that may be perhaps far from the truth. So now in terms of clinical medicine, we often have these unconscious biases that then dictate how we take a medical history, how we diagnose someone with a particular diagnosis, and this may lead to further disparities in care. For instance, someone comes into our emergency department. For whatever reason, we think that that person is just influences the questions we ask. We dig deep into to try to find that person out. Instead of figuring out their comorbidities, what medical problems they truly have, we may prescribe, overprescribe, or underprescribe a certain medication, and that leads to perpetuations of disparities in care. For all of you, you may see this in psychiatry as well, where I'd commonly hear they're not suicidal, they're just here for a sandwich because they're undomiciled. How does that lead to what we ask, what we do, what we diagnose that person with? I think it's important as we move through the rest of this exercise to introspect. We cannot transform our institutions unless we start to engage in daily introspection, reflection, and recognize our own biases, how we may gatekeep for certain institutions, and how we can do that in an anti-racist way. So if you feel comfortable turning on your cameras for this part, it would be great. If you cannot do so because of where you are, that's completely fine. But I would still like for you to listen to the statement, think about it. If you can, just look at how others are responding as well. If we did this physically in a space together, you would physically end up in a different space than others. But some of the statements I am about to state can be challenging to answer and to receive. While I encourage you to challenge yourself, if you do not feel comfortable sharing, you may, of course, abstain. And we recognize that this exercise can be more difficult for some who are affected in certain ways. Okay. If growing up, you could find dolls or action figures with your skin color, raise your right hand. If English is your first language, raise your right hand. If you grew up with parents of the same race, raise your right hand. If you ever lived in a neighborhood where you were the same race as the majority of people living there, and it was considered a quote unquote good neighborhood, raise your right hand. If you are guaranteed to have your religious days off, holidays off from school or work without requests, raise your right hand. If because of your race, people automatically assumed you were not American, raise your left hand. If you feel that you have to work harder than others to succeed, raise your left hand. If you think that society would look down on you for having multiple sexual partners, raise your left hand. If you have ever been worried about leaving your glass unattended at a party, raise your left hand. If the waiter usually hands you the bill, raise your right hand. If your strong emotions or anger are often attributed to PMS, raise your left hand. If you can walk into a patient's room and people will automatically assume you are their doctor, raise your right hand. If you could be legally married and recognized throughout the US to your life partner, raise your right hand. If you grew up with enough food to eat, raise your right hand. If no primary caregiver in your family ever lost their job, raise your right hand. If you were able to travel internationally, raise your right hand. If your family expected you to go to college, raise your right hand. Thank you so much for participating in that exercise. I know that you're sharing a lot of yourselves. If any of you feel comfortable just stating how you felt while engaging in that exercise, I'd appreciate hearing some thoughts.
Hi, this is Tanuja. This is the second time I've participated in this exercise. The first time in a group I knew professionally, but still with a lot of people who were senior in different capacities to me. And this time in a completely new group where I don't know most of the people. And every time I think for me, the reflection is that it makes you feel very uncomfortable and visible in ways you're not comfortable with. I'm basically very vulnerable because there's so many, I think we're so used to camouflaging and hiding our vulnerabilities in general, despite how achieved we are as professionals. And speaking for myself as a woman, that when someone points that out and you have to own it, it's still very difficult. It's hard to own who you are.
Thank you so much, Tanuja. Those are some powerful comments. And I see other folks sharing in the group chat as well. Thank you for sharing. Anyone else would like to share thoughts?
I will say, the one question that I hesitated on answering, which still shows how much, as a gay man, it affects me, is the stereotype that gay men are promiscuous. The question was about multiple sexual partners, and I waited for people to actually raise their hands to raise mine, which still goes to show that at my age is still very present in me.
Thank you for sharing. So powerful. We've had that before. All right. So why are we here tonight? Why are we together sharing this important space? Why are we forming a community together with some of you I hear all the way from Hawaii, sharing this space together? So oftentimes when we think about racism, we look back in history and we compartmentalize. So racism codified into law and racism codified into science. However, we know that we can't compartmentalize like that. Various nodes have intersected structurally to create the very racist society that we live in today. So, slave ships arrived in North America, and then we had institutionalized slavery from 1619 to 1864. Around that time, Sistema Naturae in 1735 established a four-tier racial hierarchy with white people at the top and black people at the bottom. Science continued to provide evidence for these differences, for the inferiority of black people. So Dr. Morton reinforced racial hierarchy, associating intelligence with skull shape. In 1787, we saw the 3/5 Compromise, which codified enslaved black people as 3/5 of a human being. We had the Jim Crow laws, which restricted the rights of Black Americans. And then, Tuskegee is often seen as a singular episode or example of scientific racism. We know that that's not at all the case, and we'll go on to talk about that further. Plessy versus Ferguson upheld racial segregation, so separate but not equal, or separate but equal. We know that that can't be the case. Housing discrimination, redlining, and segregated care. Well, the case study here is tonight is New York City. And then we, scientists, physicians, the public health communities often fail to intervene. We often fail to treat issues, social issues as public health crises, like racism, like violence. In the United States, we had the war on drugs, the highest incarceration rate in the world, disproportionately affecting Black men. So so we're on the same page. Many people have various definitions of racism. I tend to use Dr. Kamara Jones, the past president of the American Public Health Association's definition, which is that racism opportunity and assigning value based on the social interpretation of how one looks. Once again, nowhere do you see biology or genetics. And it unfairly disadvantages some individuals and communities. A lot of times in academic medicine and even in public health, we think about the marginalized, the vulnerable, the disadvantaged. But anytime you have a group of people who are disadvantaged, you must have another group who are advantaged, who are benefiting from the oppression of others. What we often don't recognize is that racism saps the strength of the entire society through a waste of human resources. So there are different levels of racism. Institutionalized racism accounts for the link between socioeconomic or racism. So it's differential access to goods, services, and opportunities of society by race itself. Personally mediated racism is what you may traditionally think of racism. Differential assumptions about abilities, motives, and intentions of others according to their race. And then internalized racism is acceptance by members of the stigmatized race of negative messages about themselves. Devaluation. I can't do it anyway. I can't become a doctor. Nowhere else, no one in my community is. I can't become the engineer. It's not even worth it. You all know this, but a health disparity is a preventable excess impacts a group of people. In contrast, healthcare disparity is, we account for that. So it's racial or ethnic differences in the quality of healthcare, not due to access-related factors or clinical needs, preferences, appropriateness. Health equity is what we all strive for. So attainment of the highest level of health for all people. So we should be very cautious about our language. So people of color are people from the Americas, Africa, Asia, and the Arab world, Asian Pacific Islanders. So people of color have chosen this term as a shared identity that unites different racial and ethnic groups that all share an experience of racial oppression. The term people of color is used instead of minority because the term minority can be dehumanizing, and because people of color are in fact the majority of the world's population. Also, non-white, which is commonly used, implies that white is a norm. Black people are not a monolith. Once again, Black people are not a monolith. And we'll go on to talk about that further. This happens very often, tone policing. So the content of anyone's statement is the emotion that comes with it. So if you accept me, if you accept my opinion, my lived experiences, then you must accept my frustration, my anger, my humanity as a whole. White people in Birth of a Nation, it was explained, white people did not exist in US law until 1681. So this was when laws actually prevented marriage between white people and people of color. And this led to further segregation, driving division between groups spatially and in more ways than just location. White privilege and white supremacy we'll go on to talk about. So here now, you all know the data on disparities, but this was in the New England Journal of Medicine in 1990. And these authors looked at mortality in Harlem, which was predominantly Black, inner city, urban neighborhood, Bangladesh, which I hate to use the word third world, but it was it's developing country at the time stricken with natural disasters. And then they looked at US whites. So they saw that men in Harlem at the time had higher mortality than men in Bangladesh. And you see a similar pattern for women, except that US whites had decreased mortality compared to the other two groups, but it's often cited that gender inequality in Bangladesh accounts for the greater death rates of women in general. These authors concluded that Harlem and probably other inner city areas with largely Black populations have extremely high mortality rates that justify special consideration analogous to a natural disaster area. So think about that, a natural disaster area. What has been done from then to now? So the Institute of Medicine report, which it was the first report on disparities between people of color and whites in the US, looked at more than 100 studies. Some of them were randomized control trials, some of them were systematic reviews, some of them were case reports, but most of them controlled for variations in insurance status, patient income, and other access-related factors. They all found that the majority of these studies showed that the people of color are less likely than whites to receive both emergent and elective procedures and medications, interventions as a whole. So why is this the case? So race itself was constructed as a hierarchical system that privileges its creators. So there's a long history of hospitals and physicians performing experiments on Black people. Some schools practice exclusively on Black bodies, and slaves were sold to hospitals as clinical material. In the 1800s, to attract students, schools would often advertise abundant, quote, clinical material and cadavers. We've all trained within this system where teaching hospitals are purposely placed in low-income communities of color for research and dissection purposes. In 1810, there was a proposal to move Harvard Med School from Cambridge to Boston to use poor Black and white people from almshouses. We see this system even within our residencies. So whether you're practicing in New York City or beyond, oftentimes third-year medical students, once they reach that clinical stage and they're told to choose rotations, we tell each other to go ahead and choose the site where you can do more and where a patient won't say no. So for instance, I went to medical school at Mount Sinai. Back then, the mantra was go ahead and choose Elmhurst for your clinical site because you can deliver babies in the hallway, because you can perform procedures, and because if you choose Mount Sinai mainland, the population there will tell you no. I see this again at Bellevue and NYU during residency. So now we know also that whiteness is normalized at the top of the racial hierarchy in the United States. Leadership at many of our institutions, particularly academic specialty centers, are largely white. Target patient demographics are largely white. When diversity is used, it's used for marketing. And you would think that many of our hospitals are made just for English-speaking patients. This here is the leadership at my hospital, NYU. This is the senior leadership. I am not singling out any one institution. I'm saying that we are all part of the system, and we must invest in making our culture, in making our world of academic medicine better. It is the same in most places, unless there's an intentional, systematic attempt to change it. This is the senior leadership at Mount Sinai in New York as well. And then racism and capitalism are inseparable in the United States. The author Kendi, who I recommend you all reading, described racism and capitalism as conjoined twins, because the origins of racism cannot be separated from the origins of capitalism. In the United States in particular, there's a legal system of white supremacy. So who usually wins at the game of Monopoly?
The person who buys everything.
The person who accumulates the most wealth, the person who buys everything. And people, I honestly can't remember ever playing Monopoly, but people who study this game actually try to figure out who that person is, who accumulates the most wealth. And it's typically one of the initial players. It's one of the players who started the game. So think about the system here where slaves, Black bodies, were first used as property, abused in the medical system. We had a system where slaveholders were insurance for lost cargo when a slave escaped. How do we get to equity? Now we have a system of segregated care that we'll go on to talk to. Medicine and healthcare delivery, in my opinion, should always transcend the detached, transactional, and often ruthless nature of the free market. But we often forget that our country maintained a government-sanctioned system of apartheid, and where we continue to perpetuate capitalism every single time we stay silent when we practice within one of these systems. Why are institutions this way? You can't, it was Nelson Mandela said, you can't have capitalism without racism. Tim Wise said that the history of America is a history of rich white men telling not rich white people that their enemies are Black and brown. So we can rise above the system the way it is, but how do we go about doing that? So we have to believe in this vision. So this is a continuum on becoming an anti-racist multicultural institution that I hope that you all can take back to your institutions. So we no longer practice in places that are exclusive, segregated institutions that intentionally or publicly exclude or segregate African Americans, Latinos, Asian Americans, community, or women. But many of us may see ourselves at institutions at number 3 here. So symbolic change, institutions that make official policy pronouncements regarding diversity, that may see themselves as non-racist with open doors to people of color, that carry out intentional inclusive efforts, recruiting quote unquote someone of color on often a diversity committee, but they may not accept those who make waves. There's little or no contextual change in culture, policies, or decision making. So we want to get at a fully inclusive, transformed institution in a transformed society. We've seen that a lot of things that we think are idealistic are truly just realistic. Wanting healthcare for all human beings should not be idealistic. Wanting basic shelter, food for our patients should not be idealistic. So this is a future vision of an institution and wider community that has overcome systemic racism, where the institution's life reflects full participation and shared power with diverse racial, cultural, and economic groups, all of those people determining its mission, structure, policies, practices. So in terms of explaining health inequities in our system, it was, we, the public health community, often many years ago, relied solely on genetics. So Black people were genetically thought of as inferior compared to whites. This was used mostly to justify slavery. And choices hypothesis. So people are lazy. They're just milking the system. People just want welfare. But ask yourself, do people want to live in poor housing? Do they want higher rates of asthma? Do they want higher rates of incarceration with a school to prison pipeline? Do they want higher rates of mental health crises in their street? Clearly the answer is no. So we should get at the most accurate explanation for health inequities, and that's racism or social deprivation in communities of color. So how do we go about doing this? So I work with the People's Institute for Survival and Beyond, and key practices or principles that we should undo racism. But here we recognize that racism didn't just appear. It was consciously and systematically constructed. So we must consciously and systematically dismantle it. We must develop leadership intentionally and systematically. So if you are white and you are the leader of a certain working group, a department, a division, ask yourself how you would feel about having a person of color in that role. How would you feel about actively recruiting a person of color, or a woman, or someone from the LGBT community, or another group that's often marginalized? Would you sacrifice your position to bring someone else along? We must maintain accountability to the communities that we took an oath to serve. And we shouldn't just network for our own growth, to bolster our reputations, to publish in high impact journals, but we need to build a net that works so none of us can fall through. None of our Black and brown colleagues, none of our patients, no matter how poor or rich they are. And we must analyze power. So that is identify and unpack the systems external to our hospitals. Come outside the ivory tower and recognize who often doesn't make it to our clinics and to our hospital systems. So in terms of a framework to think about clinical medicine and racism, it is unfortunate that we tend to shift blame a lot. We don't think about ourselves often. But anti-racism is an active and consistent process of change to eliminate individual, institutional, and systematic racism. So as we seek to identify and dismantle racism in medicine, it is useful to think about racism using this anti-racist framework where we push back against either or thinking and recognize that racism is ever present and our work must be consistent. So we must get rid of this like ignorant versus progressive, bigoted versus educated, prejudice versus well-intentioned. I can't tell you the number of times racist behavior was defended by, oh, but that person is well-intentioned. Or mean versus open-minded, old versus young, Republican versus Democrat. We must recognize that it starts with ourselves, and it starts with love, empathy, humanism, compassion, and introspection. So in terms of white supremacy principles that often make their way into clinical medicine, there are a number of them. Either or thinking. So here, this is where things are viewed as either or. So people are either good or bad. Patients are adherent or non-adherent to treatment. And inequities are viewed as isolated incidents. The way we push back against this is to recognize or to have us all clinicians strive for understanding context and intersectionality. So patients can be both non-adherent to a treatment recommendation and also deeply committed to their own health. Power hoarding is where power is viewed as limited. So we see this all the time. So ideas from patients and communities are treated as not as worthy of inclusion or seen as a threat. So clinicians always assume, or we tend to assume, that we have the patient's best interests in mind. And clinical information and clinical decision-making is not openly shared with our own patients, their own information. The way we push back is power sharing. There's also defensiveness. There's an absence of space to air grievances or concern. Clinicians and health systems focus on protecting power instead of addressing harm. The way we push back is realizing and embracing our own vulnerability, where we create actively a space for patients and families to address their concerns. The focus on individuality is where patients act as individuals, devoid of connection to community unless we're trying to explain bad behaviors based on that community. An individual is responsible for controlling their environment. So we take that patient out of the context of communities where they may be oppressed. Then there's also the right to comfort, where clinicians often value politeness over honesty. How many times have we heard the term difficult patient? That person is a difficult patient. How do we push back? Direct and construct feedback, where we actively create a space where patients can question and challenge the clinician and medicine at large. Lastly, I think all of you are better than most of medicine with regard to the worship of the written word here. So clinicians relying exclusively on published data and don't take into account other ways that information can be shared. We can push back by once again centering the experiences of our patients and their communities. So we must deconstruct dominant narratives that we must share power. We can generate alternate hypotheses about why something is the way it is. We must decenter ourselves and center our patient, personalize the patient, and challenge scientific racism. So for the next part here, when you see, you're quickly looking at a chart and you see a person has multiple missed appointments. What is the dominant narrative in medicine? What do you often think? If not you, what do providers often think?
Difficult, uncooperative patient.
Yeah, difficult, uncooperative, patients who miss their appointments.
Lazy. Avoidance and shame.
Yes, yes. That person doesn't care about their health. Sorry, say again?
Substance use disorders.
Okay, so that person has a substance use disorder. So the way we would use an anti-racist clinical skill set here to push back is to develop a differential diagnosis as to why this person is missing their appointments and explore that. Is it on us? Perhaps that person, has a 9-to-5 job, absolutely cannot miss work, and shows up without fail 8 p.m. in the emergency department for a medication refill. How has our system left that patient outside? What other comorbidities, what other structural factors influence the care of our patients? Here, previous doctor's assessment and plan reads 55-year-old man with poorly treated depression. He refuses a second-generation antidepressant after failing an SSRI. Here, the dominant narrative is patient refuses medical care. He doesn't want to get well. He's not invested in his care. But we must push back, right? Consider the innumerable reasons why a person may not want to take another antidepressant. And figure out how we're documenting as well. That person fails an SSRI. We tend to shift blame onto our patients. Here, it's not treatment refractory depression. It's poorly treated. That person did not treat their own depression. And here, this is more of an emergency department case, but you see a Black patient in the ED trembling from pain. His chart has multiple ED visits over the past month for pain. And then the nurse says that he can't give pain medications right now because he's unsure if he can run the pain meds through the same port as a heparin port. I can't tell you the number of times I've heard the term that person is playing the system just based on how he or she looks walking into the door. This is grounded in history. So all of you may know that this man here is James Marion Sims. He is often thought of as the father of gynecology, surgical pioneer. Many people don't know that he made a name for himself, conducting hundreds of experiments on 33 Black women, slaves. He described that while he did these procedures without anesthesia, one woman, Lucy, was crying, agony, wailing. He documented in his own memoir. I thought she was going to die, he said. But he didn't stop. When his transvaginal fistula repair was finally perfected and anesthesia was available, he then offered the procedure to women. Scientific racism, once again, comes from the belief in biological evidence of race and racial inferiority or superiority. It provides a rationale for slavery. So this is a real ad by a physician in 1830. Any person having sick Negro is considered incurable by their respective physicians, and wishing to dispose of them, the highest cash prize will be paid upon as application as above. But that's scientific. What was happening at the same time? We had many caricatures, once again, portraying various stereotypes about Black men. Laziness, Jim Coon. These caricatures promoted misrecognition, oppression, dehumanization. Think about how after a Black man today is shot by someone tasked to ensure safety, how that person is posthumously depicted in media, in literature, in newspapers. Eric Garner's weight was used against him. His sacred, which should be confidential, medical chart was used against him. He was obese. He died because he was obese. He died because of his cardiovascular risk factors. He died because of his asthma, not because of someone else harming him or killing him. And then some folks, some Black men in particular, are called barbarians, Tasmanian devils. A young man was experiencing a mental health crisis in the street. Police arrived on scene, and one of the police officers called him a Tasmanian devil. Didn't just lead to stereotypes about men, but this is Sartre Bartman. She was smuggled from South Africa to London in 1810, and she was put on display in freak shows. Even after she died, her body was dissected and her remains were put on display. Her body was once again used to provide scientific evidence for the racial differences or the inferiority of the quote Negro race, to hypersexualize Black women. There's a long history of anti-Black racism in medicine, and it doesn't end in the 1800s or the early 1900s. It's continued. But those beliefs, those experiments, that behavior that was perpetuated by us, by medical providers, led to false beliefs. So in 2016, more than 200 white medical students and residents were surveyed and asked beliefs about biological differences between Blacks and whites, or Black people and white people. And more than half the sample believed at least one belief that was truly false. So for instance, nerve pathways were different, coagulation pathways were different, they felt different levels of pain. The same group of people that believed a false belief would go on to undertreat Black people in a case of a kidney stone or a fracture compared to the white person. We see these racial disparities in pain management of children as well in emergency departments. What about this ED triage note that reads EDP? I don't know how many of you have seen that, EDP. I don't know if it's used all over the country. I know for sure it's used in New York. So emotionally disturbed person. How many of you have seen this? So there was a, I call it movement of body bags, where for 2 or 3 years, patients were transported, patients experiencing mental health crises in the street were transported to emergency departments using body bags. This is one. And the justification is that rather than shoot someone, you put them in a body bag and transport them. So finally, the New York NYPD and the Department of Health in New York City is no longer using the term emotionally disturbed person. In New York City, up until this point, or over the past 3 years, more than 13 to 14, I don't have the exact number, I think it's 14 individuals who were experiencing a mental health crisis in the street were shot by a police officer who wasn't equipped with the tools of de-escalation. So unfortunately, the NYPD or police officers all over the country are tasked with addressing issues of public health, homelessness, substance use disorders, alcohol use disorder, mental health disorders. And oftentimes they're not equipped with the tools to adequately do so. We, the public health community, have failed our patients. And because of that, patients often die. When a mental health provider accompanies a police officer, the situation is often safer. So in New York City, only after the death of Saheed Vassell in Brooklyn, some of you may be familiar with his name, only after his death, we instituted here mental health co-response teams where trained mental health workers would be joining police officers responding to these 911 calls to reduce deadly encounters between police officers and New Yorkers experiencing psychiatric crises. However, unfortunately, this co-response team system, so these you have to make an additional call, so these teams are underutilized. So we won't get into alternatives to policing too much, but I will say that we must intervene. The public health community must intervene so that we can safely take care of our patients. Your expertise is needed. So let's transition to segregated care briefly. In New York City, is one of the most residentially segregated cities in the country, one of the top 3. There's something called the Dissimilarity Index, which measures the differences in location between one group versus another. So a high number is anything over 60. The white-black dissimilarity here is over or close to 85 in New York, which means that a whole census tract would have to move to another zip code, another census tract, in order for the two groups to have equilibrium or to be equated. So we know that our zip codes often impact our health outcomes more than our genetic codes. So when I was in medical school, I looked at these differences using Department of Health data. So just blocks apart in East Harlem versus the Upper East Side, life expectancy was over 10 years. Incarceration rate, health insurance. Both of these are actually ludicrous. There's no reason 12% of any community or 24% should be uninsured. But late versus prenatal care, differences that anyone can appreciate. So when we describe segregated and integrated, we define integrated as meaning that a department or a clinic sees patients of all payer types, public insurance, private insurance, no insurance, in the same location, by the same physicians, at the same time, with the same quality of care. So what results in segregated care? When there's differential access, resulting in differences in times of operation, level of continuity of care, level of care coordination, and outcomes. So in New York City, there are public hospitals, so the H&H hospitals, Kings County, Elmhurst, Bellevue, just so you have some. There's private academic medical centers, the NYUs and Mount Sinai, New York Presbyterian, and then there's private non-academic hospitals. So these hospitals tend to take care of a more similar patient population as the public hospitals. In terms of health insurance, we know that of patients who are uninsured, they're disproportionately Black and Brown, Black and Hispanic, and patients who have Medicaid are disproportionately people of color as well. This is data from Ruza Takinen, and basically here it shows that patients of color are disproportionately served at public hospitals. That is not surprising, right? But academic medical centers, specialty centers, take care of 3 times fewer patients in terms of percentage people of color, in terms of Hispanic patients, than public hospitals. Academic specialty centers see 6 times more white patients than in public hospitals. We see the same thing in terms of race. And patients of color and uninsured patients are underrepresented at academic specialty hospitals, even when you account from various other factors. So insurance status, illness severity, and many other factors. So we create the system here when hospitals nearly are, take for instance Bellevue and NYU, are taking care of wildly different patient populations, where this hospital, many of these hospitals are nonprofit. They have a social mission, they call themselves nonprofit. They actually receive funds, disproportionate share funds, etc., to take care of patients with no insurance and with Medicaid. Yet the populations are wildly different than their neighboring public hospital. If you don't call this looting, I don't know how you describe looting. Many years ago, 2 of these hospitals were accused of segregated by race. One was seeing Black and brown patients who were delivering their babies in a separate floor, particularly in the basement, versus white patients delivering babies in a top floor of the hospital. So let's look at this some more. If you have private insurance, you're seen in this building at Mount Sinai. If you have public insurance, you're seen at this building. It's called CAM. So you often receive different care. Let's talk about it. So if you have public insurance, you're taken care of by students, rotating residents, rotating fellows. You have no doctor to call your own. There's often a lack of communication, coordination. When you are sick after hours, you're automatically sent to the emergency. Private insurance, you're taken care of board certified faculty physicians. You have a doctor to call your own. There's great continuity of care. And there's an after hours covering physician. So students did a study where they did secret shopper calls as a preliminary study to these 2 centers trying to make an appointment. They used various scripts. For gastroenterology, it was a pretty acute concern. I've been having intense abdominal pain, noticed blood in my stool. I just moved to the city and I'm trying to make an appointment. Other scripts were used for various other complaints. Here you see, this is the clinic with public insurance, IMA, and FPA takes care of patients with private insurance. Here, once again, primary care, 3 days you're waiting versus 21. 3 days for dermatology versus 51. Remember GI, that acute complaint, 24 days versus close to 70 days. 8 days for orthopedics versus 77. Total, when you look at all this together, 13 versus 50. Even the amount of time a patient is waiting on the phone is different, 1 minute versus 10 minutes. But we blame the patient. They didn't call to make the appointment. They were impatient. We know using community tracking data that physicians are significantly less likely to participate in Medicaid in areas where the poor are non-white and areas that are racially segregated. But once again, let's talk about the looting a little bit. So here you see the payments for indigenous care pool, meaning institutions or funding, for taking care of patients without any insurance. You see the funding and you see the uninsured services provided. Look at the differences between public hospitals, funding, services provided. Funding, services provided. There's a difference there. So we taught, we went a step further and students asked department chairs and hospital leaders at one institution what the sources to or the resistance was to integration. These are direct quotes. I mean to say it's reasonable that we want everyone to get adequate care or safe care and get the right thing done. But to say that everyone has to be seen in the same office, no. If they have more money, they stay at a nicer hotel. But is health care a commodity? Is getting care at a hospital like staying at a hotel? And then we all know the bias that comes with stereotyping a patient as the Medicaid patient. They take more time to treat. They need more social services. They're sicker. And then this bias of poor and rich patients don't work well in the same waiting room. And then we went on to look at how this impacted education. So medical student education. Here, we won't dwell too much on this, but just recognize that 61% of students who witnessed separation or differences felt that this impacted their education. In internal medicine and OB-GYN were the clerkships that you saw this most. And then you all must be familiar with Allen Hospital. Maybe some of you were part of the campaign to save Allen Hospital. You may remember in 2017, New York Presbyterian Hospital sent in a proposal to the state to close the 30-bed psychiatric unit, and replace it with an expansion of the maternity ward and additional operating rooms for a new shiny spine center. Lots of strong advocacy and opposition happened. And we stalled the closure, but then during COVID, many psychiatric units went offline. The Department of Health allowed this. You know, we needed more beds. More patients had to be taken care of with COVID. But this meant that psychiatric units at Brooklyn Methodist Hospital and Allen Hospital and Northwells Syosset Hospital in Long Island all were sending their patients elsewhere. Would that have happened if the communities looked different? The average net patient revenue, something called the NPR, per psychiatric bed, adjusted for inflation, actually fell from 99,000 in 2000 to 88,000 in 2018. But the NPR, that net patient revenue across all beds, regardless of type, was about 1.6 million in 2018. In other words, that 30-bed unit at Allen, if converted to a 30-bed unit that wasn't a psychiatric unit, would generate an additional 15 million for New York Presbyterian. But what happens when we don't provide access to mental health services? We create a system where we criminalize mental health disorder, and we have a criminal justice system that doesn't intersect with the public health community, and we have the highest incarceration rate in the world. So just to review, race was created or constructed as a hierarchical system, and who created it. It affects everyone. People have looked at studies, putting a cost of disparities or inequities, and they're billions of dollars each year. Whiteness is normalized at the top of the racial hierarchy in the US. Racism and capitalism are inseparable. When asked to, science or doctors perpetuate race by supplying legitimacy when needed. Racial inequities are the result of the dominance group pursuit over social, economic, and political power. When left to its own devices, racism will perpetuate itself by encouraging people to act against their own self-interests. And now, how do we go about doing this work? We must intentionally dismantle the racial hierarchy and center those voices that are most marginalized. We must dismantle whiteness, so stop valuing white comfort over Black lives. Part of that is by having these conversations like you are today. Moving from just doing the workshop and then closing our computer and our phones and going to bed to engaging in daily reflection on our own biases, on our own racism, how do we go about stopping ourselves? How do we use our voice to hold our institutions accountable? And then dismantle capitalism. So stop valuing profit over people. We must do this work bringing in tools from the outside. In academic medicine, we constantly think of clinical care, education, and research. There's no place for advocacy. There's no place for organizing. However, we have went hundreds of years creating the system, training doctors, and unfortunately, as we move along the system, we tend to get our academic promotions, we climb the ladder, we put out our publications, we bolster our reputations, and we forget to use our voice to advocate for our patients and to stop the system the way it is. So this is a document that was put together by Catherine Russell. It's much longer than this, but this is the checklist for white allies. And obviously, you don't have to go through this and put the scale, but I think it is a good exercise for all of us. You know, let's just go through some of them. I am present at meetings to make sure anti-racism is part of the discussion. I demonstrate knowledge and awareness of the issues of racism. This point is key. Many medical education institutions, and certainly the curricula across the country, has a hidden curricula where we don't learn about scientific racism. We learn about biochemistry and physics that we often don't use, but we don't learn about the structural nodes that create the lives and the context of our patients. I continually educate myself and others about racism. I recognize my own limitations as a person doing anti-racist work. I'll make sure you have access to all of these resources. So, you know, with that said, many years ago, I saw that people were doing extraordinary work, anti-racist work, but in isolated silos. People in government, community organizers, people from my community growing up, and people in academic medicine. We weren't talking to each other, so we weren't unified. And that isolation, that fragmentation, actually just perpetuates the status quo. So with that said, I really hope that we could come together. And with that, we formed the New York City Coalition to Dismantle Racism in the Health System. And we have now more than 45 member organizations, more than 1,000 members across the city. And we work on segregated care, where next year we're going to have a segregated care symposium. We're collecting publicly available data, internal conversations with our higher ups are happening. And we plan to have segregated care town halls, including the voices of our patients surrounding Montefiore, Columbia, Sinai, Cornell. We are also working on public health alternatives to policing. And then right now, a lot of our efforts are focused on COVID and its disproportionate impact on communities of color. So I would love for all of you, no matter where you are, to join us. If you just want to be on the mailing list and be part of the group in that way, if you want to share your thoughts and your talent and your expertise to help us undo this blemished system. I leave you with this quote from Audre Lorde. The master's tools will never dismantle the master's house. They may allow us to temporarily beat him as at his own game, but they will never enable us to bring about genuine change. So if we hope to thrive in this system the way it is, we can stay silent. But if we hope to actually hold ourselves accountable to our communities, to our patients, then we must push ourselves, push our institutions to do better. So with that said, I want to thank all the members of the coalition, medical students all across the city who've been working here, and all of our partners. I know Judy Wessler was on this call, the Commission on the Public Health System, and all the people who are doing this work on a daily basis, from organizers to folks in academic medicine. Thank you all, and I'll take any questions that you may have.
Feel free to unmute yourself to ask a question. How do we contact you to join this mailing list or initiative?
Oh yeah, I will actually I'll throw both the coalition email lists in the chat, and you just have to send an email saying like, add me to the list, and I'll make sure that's done. And then I'll also throw my email in the chat. And I really apologize. Typically for the actual workshop, it's a 2-hour long workshop where there's a lot more participation. We typically send out a participant guide and resources beforehand. I'll make sure I send that over to Mary so that she can distribute it to you all.
I just wanted to comment. Fantastic presentations. I just, wanted you to know that the task force, the APA task force has, asked all the councils to come up with product that might help to, get rid of structural racism and also help residents and trainees learn how to ask these questions, these hard questions to their patients. And so I'm, I don't know if you know me, but I'm the chair of the Child Council and Gabrielle Shapiro. And we actually have we did a product, educate and which could be used for education. And so I wanted you all to be aware and keep your eyes open because the task force will be putting it online. And it's, how to dismantle structural racism for the child, adolescent, and adult psychiatrist kind of. It's a product of the task force. So I want you to know.
That's amazing. And if I have your permission to do so, I will share with the coalition and all our partners as well. That'd be great.
I think we have to ask APA permission for that.
Oh, okay. All right. Yeah.
You know how that is, but yeah, no. And there are toolkits and vignettes and it's pretty good. I think, my group works really hard at it. So yeah, once they say yes, it's cool.
Thank you.
Dr. Liz has a question.
Yeah, thank you so much for such a wonderful, thoughtful, and comprehensive presentation. I had a question and wanted to, there was something that I read, I can't remember exactly where, if it was in the press, and it spoke about how we as physicians or the health industry has taken on the issue with racism and how we have developed or trying to develop tools to combat it. Because it affects not only us, our institutions, and our patients, right? But there is a wider conversation. I think that was the argument of the article to be had at how is this not necessarily a healthcare solvable issue as opposed to a societal political issue, as you mentioned, for example, when you threw the relationship between capitalism and racism. Could you expand a little bit on that and your thoughts on it?
Yeah, I mean, I very much agree with you. I think, unfortunately, what we're seeing in medicine, particularly in academic medicine, is that, if we look at NIH funding for research projects, a lot of times people are focusing on one result of structural racism. So homelessness, opioid use disorder, X, Y, and Z, but we don't address the root cause. And it's because we as a body cannot address the root cause if we continue to do so neutrally or apolitically. We know that medicine is not apolitical. Medicine is political. So we must involve ourselves in policymaking and legislation. And part of that really is just continuing to bring people in from the outside. A lot of times when I have conversations with people within our hospital leadership, the point is that we see everybody. We see everybody who makes it to our doors. And that's true. But we don't think about the people that don't make it to our doors, why they don't, and the structural nodes of oppression that create the oppressive environment that many of our patients are living within. And I think we conversations with folks in education, folks in law enforcement, others beyond our own spheres, whether it's academic medicine or the public health community. And I agree with you that we cannot do that alone, because we'll continuously have a society where doctors are picking the issue that they can make their careers out of. I think it's important, because it's important to address these issues while we get at the root cause. We must recognize that it's systemic. It's so deeply rooted in the soil, in the two-party system, the electoral college, and every single part of America. So I hope that more and more healthcare leaders can run for office, get involved in politics, and change the system.
Amen to that. Thank you so much.
No problem. Do you have resources you can share on Structure? Yes, we do. So one of the things that we're working on actually with the Department of Health, the NYPD budget included only over the past year has included up to 10% on de-escalation training, but that does not include structural racism training at all. So our coalition has been calling for that, not just for NYPD officers, but mental health co-responders as well, who arrive on scene with police officers. So we are working with People's Institute for Survival and Beyond, who have been doing the longest anti-racism training. They're community-based, not based in academic medicine or even healthcare. So I can definitely share some of those resources if you email me, but they're definitely not, validated. There's so much more work to be done. So I think that it would be a great place to continue developing ideas and work along the way.
I had a question about child residential programs. At child long-term residential treatment programs, it's primarily Latino and Black kids. And, we find resources to treat white kids in their communities, but we are isolating these kids, institutionalizing these kids. I was curious if it's something you guys would be willing to take on.
Yeah, where are you based?
I'm in New Jersey.
Oh, you're in New Jersey. Yeah, we would honestly, that's something we've been talking about, along with the report of children of color when it comes to, so child shows up in the emergency department. So many more reports of abuse than if a child shows up from another community at Tisch. So these are both issues that we would like to work on. We would definitely appreciate the help and the expertise if you have a proposer idea that we can sort of help get through.
Yeah, I'm not sure, but it's something I care about, and it's really sad to see some of these kids don't even need to be there. It's just that there's no one to take care of them, so then they get institutionalized, and we can do a better job for them, I think.
I completely agree. I also want to just apologize. The camera on my computer is I don't have a Mac, so the PC it's at the left corner, so I'm sure that I just look like I have some strabismus the entire time. So I apologize.
I just wanted to introduce myself. I'm Shivani. I'm completely Westchester at New York Medical College, and I also work part-time at Sinai and at Lincoln Hospital as an adult psychiatrist. So I just felt like your talk, you did so much research, and it was really helpful, because I generally don't think about no-shows or non-compliant patients in that way. And I feel like it's a nice kind of opened my mind into kind of what the system has been for centuries now. So I really do appreciate that. And honestly, I was really disturbed by a lot of things. And then the other thing I wanted to ask for is if you've noticed any kind of disparities in children of color related specifically to the COVID pandemic, and kind of what it's done for families that might not be only just families of color, but also families of lower socioeconomic means, and what your experience has been with that, because clinically I see it on my end with patients that I see in the outpatients, but just curious. And if you need any help with that, you know, with that coalition you were talking about, if there's anything to do or anything to help with.
Yeah, for sure. I mean, in terms, we actually have been very involved in how COVID is playing out in communities of color in various ways. We really have not had the bandwidth to really explore in particular. So we would love that help. There is data out there. We just haven't been able to really get at it. We've looked at cases of domestic violence. We've looked at lack of childcare. Right now in the community that I'm in Richmond Hill, which is a Caribbean community, there is a spike, and automatically the community was blamed for congregating, but people don't recognize that many people live in basements, somehow up to 8 people in one apartment. Now that it's getting colder, obviously folks are inside. There's a lack of childcare. Kids don't have Wi-Fi to, you know, use school remotely. So there's so many disparities that we're looking at in East Harlem, West Harlem, Richmond Hill, but we really haven't been able to look specifically at kids yet.
Okay, thanks.
And just for the coalition list, if you're interested in one particular area, like segregated care or the criminal justice system, you could just state that in the email, because we have various working groups as well. And if you are a trainee, a medical student, a resident, or a fellow, we have a separate trainee cohort where we meet with folks, trainees really all across the tri-state area for issues. Just so you know.
This was such a great talk. So well researched, well put together. I appreciate it so, so much. I'm just wondering if anyone else has any more questions. And if not, we can disband 5 minutes early.
No, I kind of have just the same sentiments. Thank you so much. This was really good. And you've done so much work, so thank you for that.
Thank you, guys. Thank you all for having me. Hope we can.
Thank you so much, really.
Thank you so much. It was great. Thank you, guys. Bye. Be safe, everyone.